why did this question come to us that should these trackers be left or can they be taken out? And the answer is because once we were doing only 1 or 2 robotic, it was okay, you could wait your turn. But once you started running the robo between 2 rooms, it was very important to get things done very quickly. But you weren't sure it's a good thing to do or not. So that was what got me thinking. And when I looked in the literature, there is absolutely no paper on this, that can you do it or not. So I was even watching some videos of operations. Some of them were live, and I was questioning them that is it safe what you've just done, and they had no answer. So I thought, why don't I use some of my own pilot study? So we wanted to do 25, but you can see from here that one patient pin came loose, and the second, the robot malfunctioned. So I had to abandon, so I had to add 2 more. So in the end, there were 27 to start with, but ultimately 25 got that done. So the procedure is exactly what you've just seen with all the robotics replacements, so I won't go into all that. But the things we were looking at is your initial plan, your final with implants, your final thing, and the pre and post-op x-rays. So we'll start off with cases straight away. So first case, typical varus deformity, long life films. And this is your initial screen which comes on when you do the planning. And this is my final planning with this. As I said, I know that a lot of these patients have osteophytes, so I leave them a bit tight. That's what exactly I said. And you see, once you finish, even with that amount of tightness, once those osteophytes come out, you get a beautiful plan. So I'll skip. This is the trial one. This is with the final. So I'll just go back, go forth. Absolutely replica of a screen from what it was before. Now look at, this is the post-op x-ray. Second patient of ours, a bit more deformed. So that's the standing x-rays. So this is the planning. This is a bit tighter knee than the previous one. So this is the plans which we have left on table. So see the first one here, you can see there's an amount of lateral laxity. Now, why does this happen? Because in the final plan, if you see, there isn't much change. And the answer for that is, when you're doing with trial implants, there is a slight amount of looseness sometimes. And that is why some of the implants, like Smith Nephews, will have 2 small holes where you can put pin in, and that gives you a rock solid. So if this happens, put that pin rock solid, because in the trial it won't happen and you still get a good picture. So third case, again your trial, what you've done, initial gap assessment, your implants, that's what your final planning is. That's what your final thing is. Now what we do is, if we get 2 mm laxity on medial side but well balanced on the lateral side, so those cases we wouldn't go and actually cut a bit more tissue. What we would do is we'll actually put a deep dish insert there. So you see here post-op, final x-ray. Next patient, again varus deformity. This is how you see again a severe one, minus 7.9, 8.8. This is a plan which we have left it, and you would invariably see, as was Krishna was also talking to you, that 2 degree varus on femur, 2 degree on femur, and on 2 degree on TB. I found this bails you out from a lot of cases which you would normally not get out of it. So this is what you have done on a post-op trial and post-op on final implants. So this is what the x-ray is. Again, final case, same story here, initial plan. So this is the planning after what we've done corrections. This is the case where I would say that if you have 2 mm laxity, we would go deep dish, and on final you will actually correct. So once we actually did the data for these 25 patients, we realized that there isn't almost any difference between the trial implants and the final implants. So we would say very confidently that it's okay to remove the trackers. And it also tells you that if you stabilize your trial implants also, you would get a better picture. So if you have an implant which doesn't have stabilizing things when you're doing trialing, and sometimes the cuts, even when you do saws, it doesn't be all that accurate. So there's a small amount of toggle which gives you this lax pictures. But when you do it with the final implants, because cementation has been done, it doesn't happen. And if you have slight laxity, for us it's easy, same base plate, switch to deep dish. So I think what is the reason for us to remove trackers? One, as I've already said, for bilateral cases, you want to start cleaning it and actually be ready for the next one. Sometimes the machine itself has to be moved. And when you leave some pins for much longer, people are moving around, hands are moving around, you may knock them off also. And you may actually cause looseness and pin track complications. So overall, looking at everything, I think if there is a study which tells you that it is safe to take out thing, and this is a pilot study which will carry on with a much larger patients, and I would look actually at feedback, what else can I add to this study apart from making it more suitable for everybody to actually go for it. So I think with this small pilot study, I can safely say these trackers can be removed. Thank you.